Hi, everybody. It's Drew Heinmiller here from VisualSonics. Thanks for joining our live webinar today. We've got a guest, Laith Sultan, who's going to be talking about a radiomics approach to assess diagnostic and therapeutic ultrasound of liver fibrosis and hepatocellular carcinoma. A couple of things before we get started. We will be recording this webinar, and the recording will be made available a few days afterwards. We're going to mute all the lines for the duration of the webinar, and you feel free to enter questions, though, throughout the webinar using the Q&A button. Those questions will be collected, and then we'll do our best to answer them at the end of the session. Expected duration is around 45 minutes, including 10 or 15 minutes of questions at the end. Okay, I'd like to introduce our speaker today, Laith Sultan. Laith received a Doctor of Medicine degree from Al Nahrain University in Baghdad, Iraq. And he worked as an intern physician after graduation for a couple of years at Al Khadimia Hospital in Baghdad, in which he gained experience in medical fields, sort of rotating through internal medicine and surgery, pediatric, gynecological, and obstetric departments. And then he did radiological training for 3 years with a focus on ultrasound. He currently works as a postdoctoral fellow in ultrasound imaging at UPenn in the ultrasound research lab. This is Dr. Sandy Siegel's lab at UPenn. And he also is doing a part-time MPH student at Johns Hopkins University, the Bloomberg School of Public Health. He's expected to graduate next year with a focus on informatics and global health. He's developed a unique and insightful understanding of basic research needs and integrating those with clinical applications. And this came as a result of combining his clinical background as a resident physician along with his current work as a researcher at the University of Pennsylvania. His research achievements so far include publication of multiple papers and abstracts in clinical applications of quantitative computerized ultrasound imaging in significant health issues such as breast and thyroid cancer, cardiovascular diseases, fatty liver changes related to diet, and such. His research interests include quantitative ultrasound imaging, computer-aided diagnosis, machine learning methods in medical imaging, preclinical animal imaging studies, and cancer imaging in general. So this is great. We're really looking forward to hearing what you've got to say today, Laith. So I'll let you take it from here.
Yeah, sure. Thank you. Thank you, Drew. Thank you, Kathy, for having me today. And thanks for giving me the opportunity to present our latest, some of our latest findings. Thanks a lot, Drew, for the introduction. So my talk today is about using radiomics for assessing diagnostic and therapeutic ultrasound of liver fibrosis and hepatocellular carcinoma. So the study, the talk today is divided into 2 major parts. The first part is about the use of multiparametric quantitative B-mode ultrasound for monitoring liver fibrosis. The second part is about quantitative multimodality assessment of antivascular ultrasound therapy for hepatocellular carcinoma. Also, we will talk about future translational models and future ideas for AVUS therapy. So first, we will talk about cirrhosis. Cirrhosis is currently represents the 12th leading cause of death overall in the US and the 5th leading cause for patients between 45 to 54 years old. Currently, liver biopsy is the gold standard for assessing fibrosis and cirrhosis, but it has its own shortcomings, being invasive, complications like intraperitoneal hemorrhage, abdominal pain, peritonitis, among others. Also, this large sampling error. So there is a need for a non-invasive, accurate method for staging fibrosis. So the objective of our study was to investigate using B-mode ultrasound for evaluating fibrotic changes in a preclinical model through using quantitative computer-extracted features in a diethylnitrosamine DEN-induced rat model. We studied 24 Wistar male rats 20 of them were given DEN. DEN is diethylnitrosamine, which is an established hepatotoxic. And the remaining 4 were used as a control group. So the DEN was given orally with the diet for these rats for 12 weeks, and the rats were followed for 13 weeks. During these 13 weeks, the rats were imaged at 3 different time points: baseline, 10 weeks, and 13 weeks. After which, we sacrificed the animal for histology validation. At each imaging session, at each time point, 6 images were acquired, including different parts from the liver for quantitative diagnosis, for quantitative analysis. So as we said, 6 images were acquired throughout the liver. 4 to 6 ROIs per image were placed on each image. 4 quantitative measures were extracted from the images. So 2 representing the brightness of the liver, which are echo intensity, which is the mean brightness of the ROIs, and hepatorenal index, HRI, which is the brightness of the liver, normalized to that of the kidney. And also 2 quantitative measures, which represent the variance, which is a measure for the coarseness of the liver tissue. There were heterogeneity, which is the local variance within the ROI, and anisotropy, which is the regional variance between ROIs. Coming to our statistical analysis, so we did, for the intragroup change, we did ANUVA with subsequent t-tests between the 3 time points. And for intergroup change between the DEN and control groups, we did 2-sided t-tests at each time point. For the pathological validation, as I said, we sacrificed the rat after 13 weeks, and slides from different parts of the liver were prepared using H&E and trichome stains, and they were graded by a vet pathologist using metaverse grading system, which is an established system. And this data was used for correlation with the sonographic findings we are studying. So coming to our results, the brightness measurements, echo intensity and HRI, both increase with time in the DEN group compared to that of the control group. As we can see here in the ultrasound images, control group stayed the same in brightness compared to that of DEN, which increased with time. And as we can see through this bar graph, and the changes were all statistically significant. Coming to our variance measurements, heterogeneity and anisotropy, they showed a similar trend, increased with time, and they were statistically significant as well. With pathological validation, the pathologist graded the tumors using the fibrosis stage, with the metaver grading system. They gave them different grades from F0 to F4. F0 means no fibrosis at all, and F4 is cirrhosis. So in radiomics, the concept is that the information reflects underlying pathophysiology. So we try to correlate our ultrasound findings with metaver scores. So there was a very good correlation, especially with the anisotropy and HRI. And the multi-ultrasound features were able to separate the metaver scores into 2 different populations, which are the non-clinically significant F0, F1, and clinically significant F2, F3, F4. So as a conclusion, B-mode ultrasound tracks fibrotic changes in a rat model. Sonographic features can correlate to histology, and potential role for B-mode ultrasound for the non-invasive measurement of liver fibrosis. The benefits of our technique is being non-invasive, wide sampling, reducing sampling error. Standard B-mode is easily accessible, quantitative measurements, objective measurements, and multi-feature which extracts multiple imaging biomarkers. As a future direction, we were thinking of comparing our findings with FibroScan, which is in use, or there are lots of studies using FibroScan, and comparison of biopsy-proven metavar fibrosis scoring with clinical ultrasound measurements. Lately, we've been studying photoacoustic imaging as a possible biomarker imaging marker for fibrosis staging. So we studied about 20 rats, imaged them at different time points, baseline 5 weeks, 10 weeks, 13 weeks. And we saw an increase in oxygenation level and hemoglobin total level with time, which really corresponds to our of the fibrosis changes with inflammation. And the 13 weeks, it dropped, I think, because it correlates to, because the liver becomes cirrhotic, so maybe less inflammation, more cirrhosis. So this is an ongoing study, and hopefully we can give more updates soon. So now we come to the second part of the talk about AVUS therapy for hepatocellular carcinoma. Hepatocellular carcinoma is the most common primary liver malignancy, the second leading cause worldwide of cancer death, and the 9th in the US. Median survival is 6 to 20 months. It's caused usually by cirrhosis and chronic liver disease caused by chronic viral hepatitis B and C, alcoholic liver changes, non-alcoholic liver changes related to diet. Current therapies are mostly surgical or transplantation with lots of complications, but not all of patients are eligible for surgical resection. So local regional therapies are a mainstay for hepatocellular carcinoma. In our studies, we are investigating a novel, non-invasive local therapy, which is antivascular ultrasound, AVUS. In AVUS, low-intensity ultrasound is used with microbubbles. Microbubbles are contrast agent used currently in ultrasound imaging. When ultrasound targets the tumor, the microbubbles in the circulation oscillates at their resonant frequencies, converting the energy from the ultrasound to thermal energy and disrupting the endothelial lining of the vasculature. So microbubbles work somehow as sonosensitizers, converting the ultrasound waves to thermal energy and mechanical force. These microbubbles are basically gas, have a gas core with a lipid shell. And they are, as I said, they are used currently for research and maybe some FDA-approved clinical applications in ultrasound imaging. So AVUS was investigated in our previous studies in a subcutaneous melanoma mouse model. We saw a decrease in perfusion after therapy. This decrease increased with time, more time of therapy, going from, if you can see the images on the right column. On ultrasound, contrast enhanced ultrasound, it decreased with time, the perfusion. It correlated closely to MRI findings and was validated with histology findings. But the effect of those was not on the vasculature, tumor vasculature was not well understood. So the objective in our studies was, the current studies, to investigate the dose-dependent effects of AVUS by evaluating tumor vascular perfusion changes pre and post low and high dose therapy in a DEN rat model of HCC. HCC and AVUS represent a good fit. HCC needs a local regional therapy. It's being a hypervascular tumor, and AVUS clearly is a vascularly directed therapy. And the high burden of the disease, so AVUS is really inexpensive and increasingly available. Coming to our models, so we use the DEN rat model. As I said, DEN is an established hepatotoxic. It's a very realistic model in terms of tumor vasculature, accompanying disease course from cirrhosis and liver changes, having multiple SCC in the background, and also provides a realistic assessment of the therapy itself by through effect of the tumor in situ and of target effects of ultrasound. So after 13 weeks of DEN, we have tumors, the right growth tumor in the liver. We have certain criteria for selecting the tumor for therapy, the size being between 6 to 15 millimeters, the location, anterior masses are usually chosen. Tumor should be well vascularized with minimal cystic structures. And after we choose the tumor for the therapy, we do a pre-imaging with two modalities, contrast-enhanced ultrasound and power Doppler imaging. And we use the same modalities to assess the changes in the post-therapy imaging, after which we sacrifice the rat for histology validation. So we used two different doses. One of the doses was the high dose therapy, in which we use the same dose we used before in our mouse model, the melanoma model, using 2 watts per square centimeter, and for 6 minutes using 0.7 ml of microbubbles, and half of this dose exactly as a low dose therapy. And we use Definity microbubbles and Danatronics D150 plus as a therapy machine. Coming to our results, so the high dose AVUS showed a decrease in the perfusion, quantitative perfusion measures we did, which are peak enhancement and perfusional index on both modalities, power Doppler and contrast enhanced ultrasound. As we can see in this example, on power Doppler imaging, there was a dramatic decrease after therapy. On the other side, the low dose showed an increase after post-therapy in perfusion measurements, as we can see in this example again on power Doppler imaging. And this bar graph shows the opposite direction of the effects from low dose and high dose. Contrast enhanced ultrasound was more sensitive, clearly, showing a perfusion index, of a change of up to 67.7% and up to 33.2 change in perfusion decrease, after high dose therapy. Histology confirmed the differential effects. Low dose therapy showed less tissue injury from hemorrhage, necrosis, much smaller and focal hemorrhage compared to large areas of hemorrhage and necrosis with high dose AVUS therapy. So to conclude, we saw opposing effects of AVUS, which can allow for multiple roles in tumor therapy. Enhanced perfusion at low doses may improve drug delivery or radiation therapy. High dose vascular disruption may allow for non-invasive ischemic therapy. Future directions, we have a lot of ideas actually. Combination therapy for drug delivery with immunotherapy, specifically checkpoint immunotherapy, inhibiting immunotherapy, and with other local regional therapies. And also we have future translational applications. So the next logical step will go with larger animals that grow naturally SCC, canines, for example. As humans, these tumors are the most common form of primary liver neoplasia in dogs. So this will be a good example to study before going to clinical trials to determine feasibility and safety. So at the end, I want to thank our team in the Ultrasound Research Lab. First start with Dr. Sandy Sehgal, our director, and Julia D'Souza, Susan Schultz, Mriganda Karmacharya, and Dr. Andrew Wood. and all other lab members, and also especially thank Dr. Stephen Hunt, who is the co-director of Piggy Lab, and thank VisualSonics for having me today, and all, and for giving me this opportunity to present our latest findings. Thanks a lot.
Great. Thanks very much, Laith. Yeah, that was a great talk. I think there's a lot to kind of go into as far as some of the details here. I've got a couple of questions for you here. Now, I know that in the clinic, and I'm no expert here, but I know that in the clinic, elastography is often used for liver fibrosis. Can you comment on that, using elastography versus using your technique, just looking at the brain?
Yeah, exactly. And so it's been used lately, and FibroScan is also an example of using elasticity. Mm-hmm. But we wanted to go with something more accessible, easier, less expensive. So nothing easier to find than just B-mode ultrasound using our quantitative measurements. So we were hoping, with these studies, with these findings, and maybe doing more studies, that this system can be established, and if it's in the future.
Okay, yeah, I want to ask you a few details about that as well. So it sounds like what you're doing is you're just choosing regions and just purely looking at brightness. How are you doing that measurement? Are you collecting RF data for that and doing analysis offline, or is it just measurements on the system?
Yeah, okay, yeah. So I'll go to the slides maybe just to be more
clear. Yeah.
Just a second. So yeah, so as I said, from each time point we acquire about 6 images throughout the liver, scanning the liver from left to right and up and down. Including as much as liver tissue we can. And so on these images we on each image we place multiple ROIs offline. We acquire these images and we use a software offline to place the ROIs and extract the quantitative measurements. No RF data currently, but just these 2 quantitative measurements, which represent the brightness and the variance, the coarseness of the tissue. But we were planning to add more features maybe in the future, going more broad.
Okay.
Yeah.
Okay. And when you're oh, there we go. Yeah, I was looking at that slide. So the areas that you choose, I've seen other techniques where they'll use another tissue as kind of a control, like using the kidney or something like that. Have you done anything like that?
Yeah. So HRI is actually what we have done. It's a hepatorenal index. So in this image, it doesn't show this. It just show the other measurements.
Uh-huh.
But I'm sorry I didn't include this image. But for HRI, we placed 3 ROIs on the kidney and 3 ROIs on the liver, and we took the ratio of the brightness from the brightness and of the variance from the liver to the kidney.
Okay.
And and the system is, I think it's used clinically now, HRI index for staging steatosis.
Oh, I see. Okay.
Changes,
okay.
Yeah.
Yeah, I didn't realize that.
Yeah.
I guess that it's actually a nice segue into my next question, which is, do you see this as being developed as a tool for the clinic? I think you kind of already answered this by saying, elastography exists, but this is maybe easier and cheaper.
This is much simpler, and so we are hoping. It can be really established, and we hope we have this happen soon.
Yeah, okay.
Our measurements, and we did another data set for the photoacoustics also, so it's all consistent.
And for the photoacoustic aspect of things, what do you envision the result being? Do you expect that that data will be used to sort of complement the data in other modes?
Yeah, I mean, yeah, exactly, yeah. So complement, I mean, we have to correlate it first with the fibrosis changes we saw. I mean, histologically first, and also with our grayscale findings as well.
Okay.
But if it holds true, it can be an individual, a separate biomarker. I mean, if it holds true, yeah.
I was going to ask you as well, and again, just because I'm not familiar, the Medivir versus the ultrasound. What are they looking for in those Medivir analysis of the histology?
Yeah. So I mean, it's an established system. There are actually two systems used in staging and grading fibrosis, but the most widely used is Medivir by the pathologist. So they look mostly inflammatory and fibrotic changes, how the tissue change with time. I mean, exactly, if you want an exact answer, it should come from a pathologist, I think, but I know they look for changes in the architecture and the fibrotic and inflammatory changes until the whole architecture of the liver changes in F4, which is cirrhotic.
Okay. Okay. Yeah. And were you able to correlate the degree of the Medivir score with the degree of ultrasound changes you saw?
Yeah,
because
exactly.
that's what we're kind of looking at here, right? As the F, oh, I see the F numbers are there. Okay, got it.
So there was a good correlation. And if you see here, we were able to, I mean, the ultrasound features were able to separate the Medivir scores into two populations. One was the clinically significant fibrosis group and the non-significant.
And this is again just purely on the echo intensity.
This is echo intensity and variance measurement.
Okay.
So yeah,
okay.
so they are measurements for the brightness and the coarseness of the liver tissue.
Okay, great, great. I have a couple other questions coming in here. How do you, one person says, how do you select the locations for the regions of interest, or is it randomized?
I mean, they are not, I mean, we try to choose as much as from the liver tissue as much as possible, trying to avoid any artifacts, any shadowing, and include different places from the image. So, and then we average them out.
Okay, okay. Another person's asking, how do you standardize the region of interest on your scans? I'm not sure exactly what they mean. I mean, you sort of answered that in that you do the comparison to the
I think it means the
kidney.
normalization to the kidney, maybe. Yeah.
Yeah. Okay. Okay.
Yeah.
Yeah. I'm just wondering about in your later studies, you're using Definity. Is there a reason you're using that? I know there's several different kinds of microbubbles. I know those are clinical bubbles. Is there any reason you use those ones in particular, or?
No specific reason. I mean, because we were using them before in our studies. I think they are more available, maybe, or
okay.
Commercially, yeah. Yeah.
Another thing you mentioned, you said, ultrasound, one of the advantages is it's multi-feature. So it uses, you can sort of use multi features to identify multiple biomarkers. Can you comment a little bit more on that?
You mean for the fibrosis study, or I mean for both? It's actually yeah. So multi-features. I mean, this is what's going now with all the artificial intelligence and machine learning trend and radiomics. So I mean, multi-feature is becoming a trend to improve the diagnosis of different diseases, and trying to correlate this with histology findings. So I mean, in this study, we try to use as much as possible of ultrasound features, quantitative extracted features from the computer, and correlate this with pathophysiology. We are also planning to add more features, maybe more texture features, and even for the AVUS therapy for evaluating the change in the tumor. So we were planning also to add more modalities, more features, so it gives us a better thought of what's happening. I mean, even go to the molecular level, maybe with using photoacoustics.
Yeah, yeah. You mentioned it, and you know, it is a hot topic these days. Is you know, deep learning and artificial intelligence and that kind of thing. Maybe I'll ask you to speculate a little bit and on the role of machine learning and AI in the future of you know, different imaging techniques.
Yeah, I mean, especially in imaging, you know, because I mean, technology is really very correlated to radiology and imaging. So, I mean, we already did a lot of studies in our lab and on machine learning. I mean, using machine learning methods and computer extracted features for improving the diagnosis and of, for example, cancer, breast cancer, thyroid cancer. Although it's not, I mean, even now for hepatocellular carcinoma. So at least it gives more confidence to the radiologist. I mean, especially for global health. I mean, in places with less expertise, if you have this system implemented on the device, and it gives you a diagnosis, or it helps or describe the lesion. So it's really push forward. I mean, I went to the RSNAs last week. So it was the major trend was artificial intelligence and machine learning methods.
So that's interesting. Yeah. No, I mean, I'm just sort of thinking of this. You know, we have a couple of you know, AI features on our system, mostly to do with cardiovascular measurements. But this is really interesting. You know, something you know, the ability to use AI to identify liver fibrosis would be a huge thing, especially as you say.
Yeah, of course. I mean, if you have enough data set, I mean, to train and test, so that will be amazing. I mean, even we can use these features to. I mean, our limitation here was the data set, but maybe in the future we were thinking of doing this using machine learning methods to train and test. So we have an established machine learning system that can predict the fibrosis stage.
Oh, great. Yeah. Well, we'll have to have you give another webinar once you've got that.
Yeah, sure. Thank you.
I think that's all we have for now. I'm just gonna take back the sharing here and just. I just want to thank you again so much for giving us that talk. It's really interesting. I know there's a lot of groups, you know,
sure. Thank you for having me. Thank you very much.
Yeah, of course. Yeah. Looking into, you know, liver fibrosis and HCCs and that kind of thing. So I think this will be really really helpful. And thanks everyone for attending. If you have any questions, you know, after the webinar, please reach out to us. You can reach out to us on www.visualsonics.com. We've got, you know, questions or request support via the web forms there. You can register for webinars at the website you see here, visualsonics.com/resource/webinars. And you can look up our library. We have dozens of webinars in our library, past webinars, so you can search by topic and find some interesting stuff there. You can, of course, find us on social media channels, YouTube and Facebook, Twitter, Google Plus and LinkedIn. And please check us out to see what conferences we'll be at. You can see that in visualsonics.com/event/preclinical/conferences and society meetings. As usual, please feel free to get in touch with us about our products or technology. You can contact us through our customer support page there. So Laith, again, thanks so much, and thanks everyone for attending. And
thank you.
Everyone have a good afternoon.
Thank you. Bye.